Well, let's go ahead and get started. This is going to be a little bit long, so I apologize, but I hope you get some value out of it and understand that the science behind what we're doing here at Brio-Medical is really, it's really evidence-based. The science leads out and we just follow it. So, and when you look at iron, I think it's a story that's often, it's not told and it's often not even realized. So I thought it was important to bring this into the discussion because we've been talking a lot about other therapies, of which we talked most recently vitamin C, especially on the Mercola show. And without iron, vitamin C is really not going to have its anti-cancer effect that we all know about. So what we're talking about here is the behind the iron curtain of the tumor microenvironment. Again, this is you see in the image in the background is a reference back to, post-World War II, the Iron Curtain. So a little play on words there. So who are we at Brio-Medical? We are a holistic integrative cancer healing center here in the beautiful Scottsdale in the beautiful state of Arizona. You can see down there a couple of our patients, one of our wonderful naturopaths, Dr. Labont. Our focus is to heal patients. That is the word physician in Hebrew. It means to healer. It means healer. And so our job and our focus is to heal. We take those words to heart and we go right after those with every one of our patients, no matter what type of cancer or how advanced or how many number times of recurrent it is. I am Dr. Nathan Goodyear. I am the medical director here at Brio-Medical. It's my pleasure to join you this evening. It's my pleasure to take care of the patients here. And again, our approach is not to destroy the body en route to healing. And that's the way a lot of medicine takes today. We must destroy to heal. And when you look throughout nature, it's just something that's not found. Our approach is to heal, and to let the evidence lead the way to allow the body to heal. And really what we're doing is we're tapping in through at least a variety of therapies that you can see at least listed here to your left on the screen, that allows us to tap into the body's inherent capacity to heal. Now, each person's different. Everybody is going to need a little bit more push here or there. But what we want to do is help the body achieve its fullest healing potential. So really the phrase Iron Curtain really goes back to Winston Churchill in 1946. If you listen to me enough, you know that I love history and I love words. History because it lets us know where we've come from. And it gives us the opportunity to learn or not learn. But it gives us the opportunity to move forward. And so Winston Churchill first talked about Iron Curtain referencing to the communist countries post-World War II. And when you look at this phrase, science is settled, you may have heard that a lot here recently over the last couple of years. And in fact, there's a quote that's attributed to Charles Duell saying that everything can be invented has been invented. Now, the problem with this quote, which is referencing that the science is settled, is it's actually an apocryphal quote, which means it's a quote that's felt to be true, but in actuality, it's probably false. So when we're talking about the science is settled, a quote here that's really talking about the invention of science that has been settled, that is, everything's been invented, it in and of itself, it is an inaccurate statement. So this kind of sets the stage for different environments within the body all at the same time. So when you look at cancer and how it's been approached basically for the last 100 years, is a very cancer-centric model. What that means is that the focus is on the tumor. The focus is on the primary cancer. That's the focus. Everything else, who cares? So it's a very compartmentalized approach in the allopathic approach to medicine. And I come from the allopathic side of medicine, but I'm also now an MD homeopath, so I understand both sides of this fence. But what has happened with this cancer-centric model is it's not really given us the results that we'd like to see. Sure, there have been some small victories here and there, but according to a recent study called the PURE study, actually in European countries, cancer is the #1 cause of mortality in the adults of these European countries, in high-income countries. So clearly this cancer-centric model is not working. And now where we are is moving rapidly into what's called a tumor-centric model and really moving into the model of omics as it relates to the tumor microenvironment. So this tumor microenvironment model is really referencing the environment around the tumor. And it's the environment that is in many ways dictating the cancer as the cancer dictates to the environment. So it's this communication, this relationship that really is driving the show. And it gives us a bigger opportunity really to influence the environment that the cancer exists in. Got a QR code here that you can take a photo of or just put your phone over, and this will take you to the study. This is a really nice study talking about the tumor microenvironment as our understanding currently is. And really it's a microenvironment, again, around the tumor that is a coexistence of several different microenvironments that these authors described. A metabolic microenvironment, an immune microenvironment, hypoxic microenvironment, we'll talk about more in a second, intratumoral microbiota, meaning there's bacteria within the tumor, acidic microenvironment, the innervated niche, the mechanical microenvironment, and then the gut microbiome. So, but really when you look at these and you look at this from a holistic perspective, you can't compartmentalize this because they're all affecting each other. And that's one of the fallacies and flaws with compartmentalized medicine today is it says, well, there's tumor. Let's kill the tumor. And what happens is we go to war on the tumor and we go to war on the body. A holistic approach says, let's step back and understand our impact on the whole. Because if we destroy the tumor but destroy the whole, we've really set ourselves back a little bit, haven't we? But this is saying, hey, there is a dynamic physiological process ongoing, and we want to work within that, influence it, change it, reprogram it, you'll hear that again, and this in turn will affect the tumor. So I referenced omics, and I've talked about this a lot. Omics is really the future of research that's really permeating medicine today. It's born out of an attempt to avoid the compartmentalized approach of allopathic medicine, particularly in the treatment of cancer, and focus on the whole. And it really has 6 different parameters here. Genomics, which is all of the genome. Epigenomics, which is above the genome, which is the expression of the genome. Transcriptomics is the genomic being transcribed into many different types of RNA, messenger RNA, long non-coding RNA. Then there's proteomics, which is all the proteins and the set of functions of these proteins, again, within the organism. So here, as it relates to cancer, we would be talking about all of this as it relates in context with the cancer or the tumor. Metabolomics, which I think is one of the most impactful, which is looking at the metabolism and the function, and that's going to be a lot of what we talk about here. And then immunomodulomics, which is a word I made up, which is simply just immunomodulation is the process by which the cancer influences the immune system in the tumor microenvironment, and which the tumor microenvironment influences the immune system to affect the cancer. So it's this immunomodulation that exists in that kind of gray zone of the tumor microenvironment. So this is the future, but it's now, and we have not only the ability to test in this, we have the ability to develop precision cancer care programs. So what we're looking at here is just creating a little bit of a graphical beginning, if you will, of how this process of a tumor microenvironment and then the iron metabolism within the tumor microenvironment, how they work together for the benefit of the tumor and not the body. So when you look at anaerobic glycolysis, this is that oncogenic metabolic shift that is associated with the Warburg effect, which everybody talks about how cancer is addicted to sugar. That's an oversimplification, but it's very true that cancer does love sugar. And so this is where cancer is using sugar very inefficiently, but for the sacrifice to gain speed as it grows very, very rapidly. From this, you get hypoxia as the tumor is growing very rapidly. It outgrows its blood vessel supply growth, and you get all of this tortuous blood vessels. So this hypoxia starts to trigger signaling, hypoxia-inducible factor 1 alpha, and this increases the collection of iron within the cancer cells, but it does so within the immune cells as well. And what happens is these immune cells, primarily what are called macrophages within the tumor microenvironment, they soak up the iron. And then what happens is within the tumor microenvironment, these immune cells that are recruited to the tumor microenvironment, and this is always really interesting, cancer will attract the immune system to it, but then it turns around and turns the immune system on the immune system. So here we see what's called polarization, where a M1 type macrophage gets converted to an M type 2 macrophage. And it's in this process, and I have a slide here at the end, where it dumps iron into the environment to be taken up by the cancer cell, which supplies its needed growth. Because just as cancer is addicted to sugar, it's addicted to iron. And then what happens here is you get a disruption of the immune system, or tumor microenvironment immunomodulation. Sorry, it's kind of upside down, couldn't get it to rotate. And you get a varying signaling that actually leads to immunosuppression and disruption of the anti-cancer immune system. So the cancer attracts the immune system to it, adulterates it, suppresses it, turns it on the immune system. And iron is intimately involved in that process. First we'll talk about the healthy metabolism of iron, because we have to understand what's normal iron metabolism to understand what is cancer iron metabolism. So normal iron metabolism is really viewed through an oversimplistic, simple iron deficiency, iron overload, and iron homeostasis view. There's really a few players here. Iron, of course, itself, which is very important for cell replication, metabolism, and growth in normal cells. There are transferrin and transferrin receptors. In fact, the primary transport of iron throughout the body is on transferrin. This is a protein, and transferrin receptors take up this transferrin-loaded iron into the cell. And this cell may be a cancer cell, it may be a healthy cell, it may be an immune cell. You also see hepcidin, which is the primary systemic hormone controlling iron metabolism systemically. And hepcidin really, and we'll talk about this in a second, hepcidin really can increase iron uptake or decrease iron uptake by its effect on a transporter called ferritin. And then ferritin, of course. Ferritin is a storage form of iron. It's a storage molecule that holds iron. There's a heavy chain and a light chain, and it can hold thousands of iron molecules. And this is kind of the prism through which normal iron metabolism will work. So looking here at this hepcidin-ferritin kind of pathway, if you will, hepcidin is a hormone primarily produced by the liver in normal healthy cells. In cancer can produce its own hepcidin, no surprise. Hepcidin will block the macrophage's ability to dump iron, so it holds on to the iron. So in a cancer cell, you can see how that might be bad if the cancer cell holds onto the iron through the blocking by hepcidin. And by the way, inflammation, which cancer loves, will increase hepcidin. And so if cancer is able to hold on to the iron because its ability to transport it out is blocked by hepcidin, cancer has all the means that it needs now to help it continue to meet that pro-growth stimulation that it needs. Once iron gets into the healthy cell here, what happens is it gets used up. It gets used by many different enzymes. It gets used by mitochondria to generate energy primarily via ATP production. It promotes growth. It promotes DNA repair, duplication, and it promotes detoxification, especially things like catalase and perioxidase. So iron is something that is intimately involved with normal, healthy cell function. Immune system is no doubt. So if somebody's iron deficient, they often are tired and their body doesn't work right. Iron is very important to the normal function of the body. But what can also happen with iron is the environment of the cancer and the tumor microenvironment will manipulate it for its own survival in the detriment of the body. So looking here, what we have is iron in the center, and we see both cellular and systemic control mechanisms of iron. Of course, systemic, the primary is via hepcidin, and that's again primarily produced from the liver, but in iron metabolism that's altered through cancer, this can come from the cancer itself. Ferritin is the transporter that hepcidin controls so that it doesn't dump it from the cells. But then more cellularly and more locally, we have what are called iron response proteins and iron response elements. So this is just showing you this is both a local and a systemic effect. And again, this is going to be kind of a recurrent theme through this talk, is that there are multiple environments ongoing at the same time. We can't broad-based stroke this and say iron is only this way, Vitamin C is only this way. Vitamin D is only this way. It is going to be dictated, its effects will be dictated by the environment it encounters. And in fact, when you look at neoplastic cells or cancer cells versus immune cells, you see equally cellular and systemic effects neoplastically, and in immune cells you see cellular and systemic signaling as well. So this is, again, we have to step back, think dynamically, think holistically, and not compartmentalized. So everybody has probably heard about the concept of anemia of chronic disease. For us here at Brio, most of our patients that come in with cancer, they tend to be very advanced, stage 3, stage 4, and they tend to be anemic to some degree. And it's because of the process of the cancer. It's called hypophoремia of inflammation. So inflammation is obviously not just connected to just cancer, it's involved in a lot of different things. But in cancer, for example, here, the inflammation, interleukin 6, it's going to stimulate signaling, that JAK2 STAT3, which promotes hepcidin expression. Hepcidin shuts down the door by which iron can be dumped from the cell. That's the ferritin transporter. What happens then is you get accumulation of iron within the cell. So if this happens to be a macrophage, which is an immune cell within the tumor microenvironment, that cell holds on to the iron. If it happens to be within an enterocyte, which is a cell that lines the gut lining in your intestine, it keeps iron there. And so what happens is iron can't be absorbed, iron can't be dumped into systemic circulation, and what happens is you get iron deficiency systemically. But what's happening is the cells are holding on to the iron. And so in cancer, that's not good. And I'll show you in a second, when the macrophages hold on to the iron and they encounter the tumor microenvironment, that is also not good. So here we're looking at just a graphical depiction how inflammation is driving this show. Inflammation, interleukin 6 down at the bottom, triggering hepcidin. These little gray dots in the middle of the circle, which is the cell, those are iron molecules. So that can trigger inflammation, DNA damage, oxidative stress. So a lot of dynamic processes ongoing by which this can initiate cancer, but it can also turn around and promote the cancer's growth, recurrence, and spread. And so what happens when inflammation is present, hepcidin is increased, you actually get a kind of what's called a macrophage retention phenotype, meaning the macrophage is holding on to it. Now I'll show you as this encounters different areas within the tumor microenvironment, it's going to unload its iron, and the cancer is just going to go absolutely nuts because of that in the tumor microenvironment. Now ferritin is, a lot of people will look at ferritin in the blood, which is a very valuable source, a very valuable, helpful tool to use in the source of treating patients. But you also have to look at iron and look at the context with which it's in. So looking at just ferritin and not understanding if there's systemic inflammation, you're kind of really missing the concept and the picture of what's ongoing. So always make sure your doctor or nurse practitioner or PA or whomever is assessing these things broadly. But ferritin has very, very broad effects. One, it's the primary iron storage, say that twice, let alone 3 times, which is critical in how the body will hold on to iron. It's very involved, intimately involved in immunosuppression, how the tumor microenvironment and the body might suppress the immune system. Here in cancer, actually there's some thought that increasing ferritin can actually bind up iron and be a way that the cancer protects itself against overwhelming oxidative stress. Ferritin is actually a biomarker of disease progression and of prognosis. So when a patient comes into our clinic and we look at ferritin, we're not just looking at it to assess iron metabolism. We're looking at it to assess where is this process? Where is this process? And gives us a tool to follow through treatment. Of course, ferritin is a good marker of inflammation. You can see over on the left, it's an acute phase reactant, which is a process of inflammation. It's very tumorigenic through the secretion of ferritin into the tumor microenvironment. This has been shown in breast cancer research. And it, of course, reduces reactive oxygen species by holding the labile iron pool or the iron inside the cell. So ferritin really has broad, but I wanted to mention it here because I've not really mentioned ferritin but it's one that many people will hear as it relates to the testing of their blood work, but it's really just a storage form, a molecule to hold iron, but you can see it has many different functions. Shifting a little bit to cancer, tumor microenvironment, iron metabolism. I love this quote right here, I think is really good. It says, research of the last 5 years implicates changes in the uptake and management of iron as crucial features of cancer, and it suggests that the alteration of the iron metabolism is a key metabolic hallmark of cancer. Key metabolic, meaning when we look at iron metabolism as best as we can in the blood, we're really getting some insight, a window into the picture of the metabolism indirectly as it relates to cancer. So again, moving away from the tumor-centric model and moving into the tumor microenvironment-centric model and the metabolomics, it's really given us a functional perspective of what's going on. So looking at the labile iron pool, this is the collection of iron within the cancer cell, not bound to ferritin. This is increased in cancer. By the way, this is one of the ways in which vitamin C attacks the cancer cell. Transferrin receptors are increased so that the cancer cell can take up the iron. Hepcidin, increased hepcidin decreases the efflux or transport out of the cancer cell or immune cell for that matter of iron. And ferroportin is blocked by hepcidin. All of this points to that iron retaining by the cell. And again, this can be cancer, this can be immune cells, it can be any cell. But here we're talking about cancer, so we're talking about it within the tumor microenvironment. The overarching theme here that emerges is that iron has roles in all aspects of cancer, in initiation, in the tumor microenvironment, and of course in metastasis, which is very important because that's where 90% of morbidity and mortality associated with cancer comes from, is when it spreads. So it's involved in tumor initiation, tumor growth, invasion, survival. It's involved in the tumor microenvironment and how that microenvironment can protect the tumor and invade and evade the immune system. And then of course, metastasis. And this is critical. Iron is critically involved in every one of these steps. Not healthy metabolism, but unhealthy metabolism that is associated with cancer. And hypoxia really drives a lot of this show. And I love this graphic from this study, this review article down below published in 2021. I always try to put articles in here and I always have the references there to give credit to the authors as they should get, because a lot of these are great works, but also to provide areas where you can go read the science yourself. And I try to put in really relevant recent research. But I want to focus here up on top because what you see that inflammation, which is IL-6, stimulating hepcidin, and then blocking FPN, which is ferroportin. That's that transport. And that molecule there that's got the kind of like little wiggly things on the end that's an enterocyte. That's a cell that lines the gut lining. And so what it's showing is iron within that cell stays within that cell. Now, there in the enterocyte, that's not necessarily a bad thing. It could initiate cancer, but in a cancer cell, that is a very, very bad thing. And you look at hypoxia, hypoxia blocks hepcidin. In fact, hypoxia is one of the key mechanisms by which that Warburg effect, that altered cellular metabolism using sugar, glucose, inefficiently for the efficiency of speed occurs. So you can see there's kind of a metabolism, a balance here involved, and hypoxia is really central to the dysfunctional iron metabolism disruption. And you look below the hypoxia, you see the glycolysis, the angiogenesis, cell survival, proliferation, and really I would add steady iron supply. All of that is what we would see in cancer. So when you look at hypoxia, and let's step back a little bit and talk about the concept of the tumor, because within the tumor and the tumor microenvironment, even within that environment, there are microenvironments. Actually, I had a patient one time and said, Dr. Goodyear, aren't you being a little bit overly complex? You know, brevity and wit go hand to hand. I said, yeah, that's true, but I'm not trying to be witty. What we're trying to be here is evidence-based. So here's a 2016 article looking at these changes in oxygen environments within tissue types. So this same applies with the tumor microenvironment, where we have pockets of normal oxygen, what's called normoxia, and pockets that are hypoxic. And as you migrate from the top there and basically go down on this slope, you go into just more and more hypoxic areas, and as a result, you get more dysfunctional metabolism. And iron absolutely plays a central role in that process. So understand that within a tumor and a tumor microenvironment, there's going to be patches of normal oxygen, there's going to be patches of no oxygen, there's going to be patches of minimal oxygen, just as when we talk about the acidic pH associated with cancer not being throughout the body because the body wouldn't survive, it's just within and around that tumor. We also are applying that to hypoxia and normoxia as it relates to the same environment. Iron is both essential and potentially toxic. Let me repeat that. Iron is both essential and potentially toxic. At the same time, two environments, two possible effects. Both the beneficial and the deleterious effects of iron have a role in cancer. So again, cancer is going to use our normal functional or normal metabolic pathways. It's going to use it for its benefit and not for our own benefit. What essentially happens is we have these two environments. On the left here, normal epithelial cells that would characterize normal cells. On the right would be cancer cells. What we essentially get is two different environments, two different metabolism. We get a reprogramming of the iron metabolism, and this is central to really the initiation, but more the tumor cell survival and the tumor cell growth and spread. So what happens in this reprogramming of the iron metabolism in the tumor microenvironment is we got an increase of iron acquisition, increase of iron uptake. You get an increase of transferrin, you get an increase of loading to transferrin, you get an increase in transferrin receptors so that the cells can take it up. So you're just delivering more iron. You also turn off the ability of that cell to dump iron out. That is the iron efflux, that's the ferritin, that's by hepcidin. Iron storage goes up. So we get pooling of iron within the cell, and we get ferritin holding on to the iron in the cell. And we also get an increase, as I mentioned, with the hepcidin, and this is being driven by systemic signal by hepcidin, but actually in cancer, you actually get a localized hepcidin stimulus ongoing. So both local and systemic. Again, kind of a repetitive local, systemic, two environments, so we have to think dynamically. This is a slide I've shown before, and I'll be using down in Florida, but it's again, same concept, two environments, two effects. This is looking at a study where they used radiation plus high-dose vitamin C. And what they found is that in normal cells, you had a decrease in iron, you had a reduction in oxidative damage to the healthy cell, and you had a maintenance of that healthy cell. So in healthy cells, high-dose vitamin C in conjunction with radiation, there's less damage to those healthy cells. But in cancer cells, you have an increase in iron in the cancer cell. You have an increased damage to the cancer cell by the radiation. You have an increased sensitization of the cancer cell to the radiation because of the vitamin C. Same treatment, same dose, different cells, different effects. Environment dictates effect. So here's the same pattern. Hyperthermia. Not hypo, but hyperthermia. Here we're mimicking a fever, back to William Coley of the 20th century. The effects of hyperthermia on normal and tumor microenvironment, study from 1980. Here I wanted to show you this was recognized some 40 years ago. Get this, these results indicate that the normal tissue microcirculation is better able to cope with hyperthermic stress. It appears that the temperature effect at which the breaking point occurs, that be cell destruction, is characteristic of the specific tissue. Environment dictates effect. So here we're looking at the representation of that normal healthy cell and cancer cell in iron metabolism. So let's break those down just a little bit. In normal healthy cells, what we see is we see low levels of transferrin receptors. We're seeing low uptake of iron by the healthy cells. and hepcidin is also low, so that we're not seeing a lot of retention within the cells, because retaining of iron within a cell can actually initiate cancer. And then there's high levels of the transport out of iron, the ferritin. So collectively, this creates a small pool collection of iron within the cell. And it can't cause damage, oxidative stress. There's enough to promote the normal functions, and that's it. Looking at cancer cells, however, there's a contrast. We see they have an increased expression of transferrin receptors, increased uptake, and you have an increased hepcidin, systemic signal, but also locally, so 2 environments, and this decreases, it blocks actually, the ability of the cancer cell to dump the iron outside of the cell. The cancer cell holds on to it, it's growing very fast, it needs the iron to build new cells, to maintain normal function, and it survives and thrives. And thus it creates a higher iron pool to be able to use. Now this may or may not include elevations in ferritin levels. And this is just, again, kind of taking you back to a slide I've showed before, trying to step back a little bit, 30,000 foot perspective, and show you the function here, because iron is intimately involved here, how vitamin C is being pro-oxidative both in the tumor microenvironment and outside the microenvironment. And I'll be talking about this down in Florida as well. Again, 2 different environments, 2 different effects. Here we're talking primarily by dose, but also different environments. Vitamin C, again, I'm trying to present different examples of this same mechanism, because I don't want you to be thinking vitamin C is all antioxidative. Iron is all bad. Hyperthermia is all good. These are dictated by the environment, that is the effect, but it's also dictated by dose. So for example, vitamin C, high dose in the millimolar concentration, as I talked about on the Mercola podcast, it's pro-oxidative in the right environment, in cancer cells, with the presence of iron. But in a non-cancer cell with normal iron, it's not pro-oxidative, it's antioxidative. But also, if it's delivered IV, it's pro-oxidative. If it's delivered orally, it's antioxidative. So this kind of almost like it's a spectrum of how the body can function dictated by its environment. And the macrophage, this is just an image of a macrophage. This is an immune cell. These are our friends. But unfortunately, what happens is the environment of the tumor microenvironment, it alters the macrophages, and it really connects the dysfunctional cancer metabolism with the dysfunction of the immune system, and this drives, in many ways, the growth and spread of the cancer. Another great slide showing you the dynamics, again, and there's a QR code, takes you to the study, just showing you how this is not a static process. This is very, very dynamic, and there's a lot of communication ongoing. There's the M1 macrophage down there at the bottom, which is normally a healthy cell in the tumor microenvironment it's an anti-cancer cell. But what happens is it shifts, and you can see that in the arrow going back and forth, to what's called the iron-donating tumor-associated macrophages, or TAMs. Some people call them an M2 macrophage. And what this does is this unloads the iron to the cancer, and the cancer takes it up. Dynamic communication process within the tumor microenvironment. But this dynamic communication process is going to be different within a non-tumor microenvironment. So iron metabolism and macrophages, really, they're at the fulcrum of the connection between cancer metabolism and the immune system dysfunction that allows it to evade and grow and spread. So iron is critical, and this dysfunction is critical in the crosstalk between the cancer cells and these immune cells. In fact, they're competing. The cancer cells and the immune cells are competing for the same pool of iron. But what's interesting is the cancer cells recognize that, but they also manipulate those immune cells. And what eventually happens is this leads to immunotolerance, where the cancer cannot be seen by the immune system, and immunoevasion. And you can see this on the slide here, where you see cancer metastasis is increased by this dysfunctional communication. And you even see there's all kinds of great things here we could talk about for hours. And I'm a nerd, yeah, I know. But down there in that little kind of brown area, it's showing this dysfunctional cancer cell metabolism and how it's affecting the purple, which is neutrophil, a type of white blood cell. Up in the blue there, it's a macrophage. So the cancer cell is manipulating these immune cells and using these immune cells for its own benefit, its own supply of iron, its own supply of bodyguards, immune protection. And it's really getting down to a process called tumor immunoediting, which is just the balance of tumor suppression and tumor promotion, and both of this can occur in the tumor microenvironment. The immune system can come in and suppress tumor growth, or the immune system can come in and support or promote tumor growth. And it's this language, this communication of cytokines and growth factors that are released by these immune cells, macrophages and neutrophils in the tumor microenvironment that alter the iron metabolism in the cancer cells, and they create a unique environment of altered cancer metabolism with iron within the tumor microenvironment that favors the tumor and doesn't favor the immune system or the healthy cells. You see these in TGF-beta, IL-1 beta, granulocyte colonase stimulating factor, IL-6, which if you recognize, I think I've heard that before. Well, over COVID, as we were talking about the cytokine storm, interleukin-6 or IL-6 was a part of that as well. So when you look at iron here, it's interesting that some research has shown that vitamin C not only attacks iron, and that's one of the mechanisms by which it targets tumors over healthy cells and can lead to their death. Vitamin C is not a chemotherapeutic. Its effects are not chemotherapeutic. Its effects are precision-based. They are immunomodulomic. They are metabolomic. They are proteomic, transcriptomic. But what we're seeing here is vitamin C actually increases the ferritin or iron storage synthesis, both in plasma and in mitochondria, and so those are different. So as we can get iron loading so that eventually it can be unloaded, and with vitamin C present, that will destroy the cancer cell, but this is small effects. Vitamin C also inhibits the breakdown of ferritin, and it suppresses that efflux of iron as well. So you might look at this and go, wait, this doesn't sound good. This is what you're saying was cancer. What this is doing is this is setting the stage for vitamin C to come in and have the ability to destroy the cancer cell. Without iron or other metals like copper, vitamin C can't do its effect inside the cell, and I'm just giving one example there. And then it increases the intestinal iron absorption and transport so that it can be pooled. So here's kind of a great, complicated but summary slide, looking at the tumor microenvironment and the gradient that's created here. And you can see that kind of solid ball of cells with a dagger through it. That's a depiction of tumor and tumor microenvironment. And you see they have referenced there M2 macrophages and M1 macrophages. What essentially is showing here is as these immune cells move through this tumor and tumor microenvironment, you see the iron, that iron shape change. What happens is that M1 macrophage retains the iron. As it moves through the normal oxygen to hypoxic areas of the tumor, it unloads its iron. And that's important because within the hypoxic areas of the tumor, they need all the help they can get to survive and grow. And that iron is the means to do it. So the environment is dictating the effect. So here we look at how the normal oxygen, the M1 macrophages, stores the iron, but as it progresses into hypoxic areas, the macrophage changes, it dumps the iron and promotes angiogenesis, invasion, metastasis, and poor survival. Now recognize all of this is not to just say, oh no, what do we do? No, we can attack this. We can attack this. We have to understand what's going on to be able to attack it. Attack it holistically, attack it naturally, attack it integratively. And this is also seen as you progress from early stage to late stage of cancer. The same process is seen because as you progress into late stages of cancer, you have more hypoxia. Things are being driven more via the hypoxic signaling, and that's going to create more contribution for this iron disruption. And this is just a study that looking at how the iron dysfunction occurs through the stages. In fact, statistical significance was seen. You can see that in the bold. They are under ferritin at less than 0.1 between stage 1 and stage 3, meaning there was a statistical significance between stage 1 early or advanced stage 3. And then transferrin, which is the transport, was statistically significant between stage 1 and every disease, which makes sense if you think about it, because as you advance, there's going to be more iron requirement. The transferrin provides it. Just another depiction again, another great study to read, showing how iron, as it goes through different environments, normal oxygen to hypoxic, here they're talking about cold versus hot, which is inflame activation or not, what we get is we get an unloading, a dumping of iron. And this again promotes the ability for the cancer cells to meet the metabolic demand, grow, invade, and spread. But the iron is really instrumental here in how the immune cells that are recruited in there, these macrophages, these tumor-associated macrophages, it manipulates them to use them for iron. And some of our greatest depositions of iron are within macrophages. I just like this slide because it was colorful. I usually like really colorful slides, and I didn't get a chance to add all the color uniqueness that I like to with slides, but very dramatic in terms of its color contrast. And what this really shows, I encourage you to read the study listed there, and just look at the imaging. It's really describing how we see hypoxic on the right and normal oxygen on the left. And you see that LIP, that's lay by iron pool. Those little dots are iron. So increasing the lay by iron pool in that hypoxic region, it's going to promote tumor growth, tumor survival, immune dysfunction, cancer spread. Whereas healthy cells, they have a very different metabolism. So not the same cell. This is just depicting two environments, two metabolic effects being dictated by iron. So essentially, there's reprogramming of iron metabolism within cancer, but what we want to do is use this, as I mentioned, to target the cancer, recognize what it's doing, how it's behaving. This is not static, and say, how do we get in there holistically, naturally, and integratively? How do we attack this? Well, here was a really nice study. High-dose IV vitamin C plus oncolytic adenovirus enhances immunogenic tumor cell death and reprograms tumor immune microenvironment. Reprograms. So essentially what they did is they used high-dose vitamin C with an oncolytic virus. This is a virus that doesn't attack and is not pathogenic to humans, but it does go after the tumor. And that plus the vitamin C actually changed the macrophage polarization. So that M2 polarization that dumps iron in the tumor and that the cancer uses, the vitamin C plus this viral therapy actually reduced those macrophages back to M1 within the tumor microenvironment and really started to reprogram the immune system in terms of a way that alters iron metabolism and really favors the body, favors the immune system, and allows the immune system to do the job, and that's the attack of the cancer. So we can use this same information on the tumor. Because what's happening is the cancer in the local environment is reprogramming the immune system within the tumor microenvironment. It's upregulating many different genomic signaling pathways, proto-oncogenes like c-MYC, hypoxia factor 1 alpha, 2 alpha, and then it's down regulating all these other enzymes, transport proteins, transporters, and so it's favoring its environment, so it's reprogramming, and iron is central to that, but we can turn around and use that to reprogram it. And so vitamin C's effects, as I mentioned, they're dictated by the environment, and the iron and the altered iron metabolism is central to that effect and what vitamin C can do to dictate. So again, not just to focus on vitamin C, but to show you that what we've been talking about in the past is connected to what we're talking about now. This is all interconnected and interrelated and usable to help the body heal. This is just showing you some different depictions of tumor microenvironment. So let's connect the dots here to start the closing. Hypoxia drives hypoxia-inducible factor. And this lack of oxygen really initiates a lot of the cancer process. Not all, but a lot. And this triggers that metabolic shift in cancer that we think about, what's called glycolysis. And what also happens is we get altered iron metabolism because of the same hypoxia. And this further drives that shift to more cancer promotion, but it also starts to promote what's called tumor microenvironment immunoediting, which is where we get the immune system actually being used not to suppress tumor growth, but actually to promote it. And it does this through iron by shifting these types of immune cells to ones that favor it, holding on to the iron, and this suppresses the immune system, allows the cancer to grow and spread. Good news is vitamin C can come in here. Not that vitamin C is the only therapy we use, but what I'm trying to do is show you the intimate connectivity of what we're doing here. Vitamin C through pro-oxidative therapy has one effect, but here we're actually influencing the hypoxia. We're actually targeting the microenvironment. We're actually targeting the hypoxia. We're targeting the immune effects. Multiple effects of vitamin C. Not to just say it's just vitamin C, but what I want to show you as it relates to any other natural therapy or holistic therapy integrative like curcumin or quercetin or hyperthermia, its effects are broad. It's like a pebble thrown in a small lake in the morning with just the dew over it. It just ripples through the body. Versus kind of allopathic medicines taking a big boulder and just drop it into the water. There's a big splash, but it's quick. And so hypoxia, just as it alters glucose metabolism, the Warburg effect, it also alters the iron metabolism. It's called the hypoxia iron metabolic switch. Through hypoxia, through the signaling, increasing the collection of iron within the cell, the macrophage is loaded and the cancer uses it to adjust the immune system, survive, and grow. So enhanced iron acquisition or retention are characteristics of tumors and tumor growth, and can be directly affected simply through the manipulation of the expression of transferrin receptor and ferritin or ferroportin. Thus, altered levels of at least some iron-regulated proteins do not merely accompany malignant change, but directly drive it. So again, this altered iron metabolism is driving tumor growth. It's not just a byproduct. So the Iron Curtain was this ideological and physical separation that existed, many years ago. But what we're seeing today is a lack of awareness and knowledge of this new Iron Curtain, of the iron metabolism. It's actually creating a physical and ideological separation because of a lack of knowledge of the altered iron metabolism that sits central to the core of the altered metabolism associated with cancer that affects the immune system, allows it to survive, allows it to thrive, allows it to spread. So here in just a couple of weeks, going to be down in Florida. Going to be an incredible lineup of speakers. These are just the keynote speakers. I'll be there myself giving 3 lectures. There'll be some time to socialize, time to learn, and time to grow, and just learn how to understand how, here we're talking about vitamin C, really works to dive deep into the process of what cancer is doing and what healthy cells are doing, and use something like vitamin C. Again, here this is called the Vitamin C International Consortium Institute, how this can be used to heal the body as you heal the tumor. So heal to heal, not destroy, to heal. So again, I'm medical director here at Brio-Medical, Scottsdale, Arizona. Here's our contact information to schedule a free consultation. Again, if you miss bits or pieces of this, or just want to read back through it again because, I don't know, you have insomnia, you can watch this on our YouTube channel and share it with friends or family that you think could benefit from this information. Thank you very much. So what I want to do now is a little lengthy there. Not too bad, 50 minutes. Kind of rushed through it a little bit. Want to kind of just go through some Q&A and see if I can get to that. Is the vitamin C level 25 grams per day in your clinic? If I come to Brio, can we increase to 50 grams or more? I would highlight or more. Here's a reason. It's not because big is always better. When you look at vitamin C, there's a lot of variables that affect the dosing of the vitamin C. Clearly and intuitively, you know, if you're 5'2", 120 pounds, sitting next to somebody that's 6'6", 360 pounds, intuitively you know, well, there's got to be a different dose. And so size, body demand, tumor burden, which is a big one, level of inflammation, a lot of things, oxidative stress pre-existing, goes in to what dosing of vitamin C is required. And so 25 grams of vitamin C is considered by standard methods as a high dose, but it's not a therapeutic dose. And so what we do here is we follow plasma ascorbic acid levels to verify that in the treatment of cancer, we are achieving an optimal blood level, plasma level, and then from that in other studies, because we don't have actual human extrapolation of this, we can actually follow this into the extracellular environment, into the tumor microenvironment, into complete saturation of the tumor microenvironment. So all areas, whether it be the normal oxygen or the low oxygen environments, the vitamin C is penetrating it, saturating it, encountering all of that iron and destroying it. And so 25 grams, it's spitting in the wind. So I have a patient here, his first week he got 50 grams. We were waiting for a test to come back. Today we went up to 100. Tomorrow we're going up to 150 grams. And we'll just have to follow his levels to see how much higher we need to go. And every dose is different. You may have one patient getting 100 grams, the next patient sitting next to him may be getting 200. You know, one thing that may help us, I think it's always important to take these deep topics and just put them out there, because, you know, conventional docs, of which I'm one, they look at the integrative, alternative, holistic therapies and movement, and they go, wow, you know, they're making stuff up. They're throwing darts on the wall and hope it sticks. What I think is important to do is let the science lead the way. We don't have to run from the science. As I've shown you, the science is there. We just need to follow it and follow it correctly. So the question about the 25 grams, if we're going to give 25 grams to every patient, every type of cancer, no matter how much it's spread, whatever stage it is, then conventional doctors would be correct in saying that's not evidence-based. That is correct. I would agree with that. But if we use vitamin C therapeutically, if we use vitamin C on the understanding of this altered iron metabolism within the tumor microenvironment, and we dose it appropriately, both in dose, frequency, duration, then we let the science lead the way of a holistic therapy, and now it becomes an effective therapy. Is it possible to use vitamin C to prevent cancer? Yes. And this is a good question, because the best answer to cancer is obviously never get it. If you get cancer, the best answer to cancer is immune system. So vitamin C can be used for prevention, but it needs to be used within a broad perspective of prevention. So here you have to consider lifestyle, diet, nutrition, exercise, very important, de-stress, good sleep. Yeah, I got up at 3 o'clock the other morning, just, anyways, working for this, reading these papers. But so it's about all of those things, plus vitamin C, plus other nutrients, plus the addition of things like alpha-lipoic acid or curcumin or quercetin or vitamin D or whatever. But I think what's important here too is to also recognize that everybody's needs are going to be unique there as well. So, you know, I think vitamins are powerful and need to be approached in a customized way as much as possible. You can do this orally here, or you can do it in a lower dose IV as well. But absolutely, absolutely, it can be used in prevention, because what we know about cancer, it is de facto a vitamin C deficient state, period. And again, as I mentioned, everybody going into surgery needs vitamin C before and vitamin C after. What is the preventative dose of vitamin C orally or IV? I think this would be different person to person. I would check vitamin C levels one time on these patients and then periodically to kind of see where their levels were. I think also other context of labs would help have a better understanding. What's the level of inflammation? What are the iron metabolites looking like, etc. What's the stress response look like, because that depletes vitamin C. So I think all of these would go into helping to determine the appropriate preventative dose of vitamin C, oral or IV. And so I think the more problems you see in those labs, the more I might shift to a combined approach of oral and IV. And I think the important thing to recognize with oral vitamin C is the literature really kind of says per hour you're really kind of limited to 100 milligrams of absorption in the gastrointestinal system. So you're really limited there. So, if somebody has really no risk values or labs look great, I think you could probably just follow that with, oral vitamin C. And then I like it in the powder, the buffered form. And that buffered form, Essence C, a product of the same company that makes Pure C, you can actually just sip on that. And you can drink that 2-3 times a day. And so you're kind of just getting steady gastrointestinal dosing of that so that you're just getting regular absorption to the gastrointestinal system. And so more side effects you might see there, the more potential for risk, I think, with labs would be where I add in maybe some vitamin C IV. Do you work with RGCC tests? I try to work in what I talk about as it relates to the genomics, epigenomics, transcriptomics, proteomics, metabolomics, and immunomodulomics. I don't work with RGCC. It's not a test that I work with. We do work in genomics, metabolomics, and all those areas. Of course, we do that with our peptide program, and we develop customized therapies throughout all of that. So talking about our 6-week program as it relates to cancer and cost, what I would encourage you to do there, Christine, is check out that last slide right there. And I think there you could call or send an email, and I think you could get a better answer to your question there. So okay. This is similar to apoptosis, but it's involving ferritin, ferroptosis. There we go, ferroptosis protocol. Ferroptosis is where you have this programmed cell death that's like apoptosis, but it's involving iron. So for me, vitamin C is one of the key ways in which I can induce ferroptosis. Now, the problem is ferroptosis is not a completely reliable process, I think. It's a relatively new understanding. When you look at the literature, I think a lot of this is dictated by the environment, so the more hypoxic environments. So in a stage 3, stage 4, when I'm giving high dose, IV vitamin C, one example. I also love artesunate, especially using those in combination. Artemisinin is another alternative. Artemisinin can be given IV and can also be given orally. These are just a couple examples. But in the hypoxic regions, ferroptosis is probably going to be more likely to be present and to be effective. But in the normal oxygen, so maybe earlier stage disease process as it relates to cancer, you're probably going to see less hypoxic. At least this is what the literature shows. Again, new knowledge comes with new time. The science is not settled. The science is not settled. The great thing about science is tomorrow, there's going to be another paper that's published. Now, what you have to do is read through the papers and go, is this trash or is this somewhat relevant? Because as a good friend of mine said today when I was talking to him, any study can be torn apart based on statistics, study design, you name it. The key is recognizing valid points within it that are statistically sound. And so when you look at ferroptosis, it's recognizing the content, the stage of the disease, and how to attack that. So for me, what I would approach is if there's high ferritin in the plasma, again, there's not studies that correlate that to the tumor microenvironment, and this is advanced stage 3, stage 4, I'm going after this with high-dose vitamin C and artesunate or artemisinin. That would be a means of how I would attack that. Again, I have to use that in context. What we want to do is we want to be precise. We want to be precise. And then through genomic testing, do we see some of the genomic effects that would tell us that this would be effective? VHL. That's a genomic marker that is used by cancer in iron and growth. Is vitamin C treatment used to treat leukemia, including hairy cell leukemia? Yes, it is. It works really well in lymphomas. When you look at the leukemias, it's a little bit more. I would say the effectiveness of high dose vitamin C in leukemia is not as strong, Ralph, in other areas. But I've used vitamin C high dose in leukemias very successfully in many types. I mean, we have a patient here right now with AML. He transitioned from CLL to AML, and his blast just went absolutely haywire. Now we're using an integrative approach, but one of those integrative approaches is vitamin C. Now genomic testing, so precision-based testing also showed us we needed curcumin and quercetin, so we've combined these together along with some targeted integrative therapies to really go after his AML. So it can be used. Leukemias are, again, a little bit dicier, a little bit more problematic there. Whoa, questions rolling. Let's see. I'm a nurse practitioner. Good for you in Georgia and Florida. Beautiful place. I'm a Tennessee fan, so not too fond of either one of those college football programs. Well, hey, college football starts next week. Got to get excited. Small practice, I've been using high-dose vitamin C. Awesome. Major ozone, fantastic. Love it. Oxygenation, pro-oxidation, different environments, perfect. Repurposed drugs, beautiful. What would you be your advice on a place to gain more knowledge on integrative cancer care, courses, certification? Yeah, great question. Myself and Lior Sher is the CEO. I'm the chairman of the Scientific Medical Advisory Board of the Vitamin C International Consortium Institute. We started this organization because one of the things that I as a physician recognized is that you can go, and you recognize this, you can go to a lot of weekend courses and find a lot of experts after the weekend course. But it's just learning protocols, it's learning recipes, it's not thinking, it's group think and saying, here you go, go. It's not really promoting evidence-based critical thinking. Because what I think we should be doing is we should be stimulating and encouraging new thought, new ideas based on science. And so what we're doing in this organization, which we want to do elsewhere, and we have training courses coming, is we want you to think. We want you to provide to us as we provide to you. We don't want you to just follow a recipe. We want you to critically think and apply this to each and every patient independently. So for me, it's been a while since, of course, I went kind of the traditional route to get into this. Started with hormones about 15 years ago, and transitioned elsewhere. And I went through some of the other routes, some of the integrative medical communities. And over the last probably 5-6 years, last 6 years, it's just been, papers. I read papers. And so I've been treating cancer now solely for 5 years. And so for me, it's just a part of what I do. I do think that this area that you're talking about is something that needs to be better cultivated, because our patients deserve it, and we as physicians should demand it. Enough group thinking, we need critical thinking. So for me, we have things coming for this. Right now, a lot of your other integrative communities are there. But we want to approach it a little bit differently in terms of critical thinking. Good question, though. Good question. Best time for vitamin C, morning, mid-afternoon, or night? Why? The question there is, what's your purpose? When you look at vitamin C, so again, I'm always going to fall back on the topic of cancer. Cancer doesn't just grow during the day or night. Now, it's really interesting when you look at melatonin in cancer. At night, the Warburg effect is slower. It's less active because of high melatonin. And then during the day, as melatonin levels drop, the Warburg effect increases. But vitamin C doesn't take time off. Cancer doesn't take time off. So the way I look at vitamin C, I have a lecture where I talk about this, where vitamin C is not just about dose. We always want to focus on dose. it's also about the duration and the frequency of that dose, because it's about the pharmacokinetics. Actually had an email that was forwarded to me this morning that was a physician. He was asking about the difference in bioavailability between ascorbic acid and sodium ascorbate. But yet in the same sentence, he was mixing oral vitamin C with IV vitamin C. So it's like the whole debate, progesterone versus medroxyprogesterone acetate. One's progesterone the body makes, one's not. It's synthetic. But they're collectively called progesterone, but they're not. So I think what has to happen is it's dictated by what you're trying to achieve. So obviously you can't do vitamin C 24 hours, 7 days a week, or can you? In cancer, you need to think big picture. So if you're dealing with inflammation, you could give vitamin C in the morning or in the afternoon. I don't think it really, if you're trying to reduce inflammation, say with an autoimmune disease, I don't think it really, the timing I don't think is important there. I think the important thing is to ensure adequate support when you're getting the IV and the oral. So for cancer, it would be day and night, be all the above. Maureen, look forward to meeting you next Tuesday as well. Of course, love to meet you under different circumstances, but we're going to make the best of it. We're going to heal, we're going to teach, we're going to hope, we're going to learn, and we're going to go after your healing potential. Not going to predict your outcome. We're going to drive for amazing results. You know, why should a physician, why should we predict out, why should we play God with a little g? We're that college football coach, you know, I'm a college football fan, that we're going to help our team believe the impossible, because you only achieve the impossible. You only make it possible by helping people see you can. Now, you never give false hope. You always say, here's where things are. But let's go after it. That's the only way you achieve no evidence of disease in 6 to 7 weeks with somebody with stage 4 cancer that's recurrent. It's possible. I've seen it. I've seen it too many times to know that I can't predict the outcome, because I may achieve something I don't know that's possible. So my job is to help a patient achieve something they don't know is possible, the impossible. So look forward to working with you, Maureen. God bless. What are your thoughts on Lynparza for metastasis ovarian cancer? Tumor tested for BRCA. Oncologist is suggesting Lynparza. Yeah, targeted therapy. You know, I think sometimes these targeted therapies are beneficial. There is no doubt. As an integrative doctor here, you know, if you break a hip, I'm not going to tell you go take more vitamin D. That's silly. You got to surgically repair it. So if you have a very specific mechanism of action here, you want to go after it in as targeted, but as an integrative way. So for example, with the BRCA, I think whether it's BRCA1, BRCA2, very important, that's a tumor suppressor gene that's turned off. You know, so Lynparza is working there, but curcumin and quercetin would also augment the Lynparza because they work great in the BRCA areas. A lot of the targeted therapies have been shown to be augmented by vitamin C as well. So all of these should be combined together. Prostate cancer was destroyed by radiation therapy. Now again, Norton checks prevent it from returning. Will take vitamin C help in the relapse. How much vitamin C would act as a true barrier? Prevention, it's a great place to be. You're no evidence of disease. It's fantastic. I think the dosing would be dictated by, again, those variables I mentioned, weight, blood work, these kind of things. I can answer this best, your question this best way, you know, at least twice a week, whatever that dose may be, 50 grams, 75 grams, 100 grams. I find the best way to start a high-dose vitamin C dosing is at 1.5 grams per kilogram, and at least twice a week. And that's based on studies in animals showing that the vitamin C, the cancer cells, actually hold on to vitamin C still significant levels at 48 hours. So there's a very different metabolism, there's a surprise, within the tumor cells and the healthy cells with vitamin C. So at least twice a week, really the best there would be 3 times a week. Is a high-dose vitamin C effective in breast cancer stage 4 with metastasis to bone? Absolutely. Breast cancer is one of the most studied cancer with vitamin C, so is colorectal cancer and others, melanoma, head and neck, a lot of great cancer benefits, especially the solid tumors and even lymphomas. Vitamin C in breast cancer is very, very, very effective as an adjunct, which means a combination, but also as a standalone. For metastasis to bone, oh yeah. Combined vitamin C, here's the integrative. Combine high-dose vitamin C, again, dosing, duration, frequency. Combine it with a very old antibiotic called doxycycline, the integrative mode. That combination together has been shown to be effective. The doxycycline pushes the vitamin C into the bone. And so it's very effective, but you need to combine that with hyperthermia, real hyperthermia now. You combine those three together and you have an incredibly effective program going after cancer in bone. Go Vols! I love that. That's great. That's great. Sing Rocky Top here soon. Do you have pancreatic cancer patients? Yeah, too many. Of course, adenocarcinoma is the most common we see. Now I want to sing Rocky Top. Rocky Top, you always be. I know I'm offending some Kentucky fans and Florida fans and all that kind of stuff. We have even a neuroendocrine tumor or two from every now and then. So we have 2 pancreatic cancers here right now. Yeah, patients. And we usually keep one here quite regularly. It could be very effective there as well. Stage 4 glioblastomas, tumor on the pons. Yes, there's many things that we can do for glioblastomas. We actually had a patient that did incredibly well with glioblastomas. With glioblastomas, a lot of it, this is a brain tumor, very aggressive. A lot of it is dictated by the localized effect in the brain. How big is the tumor? What kind of swelling do you have? And those kind of things. And that doesn't just apply to what we do, Julie. That applies really for any conventional treatment, because obviously in that close confined space of the brain, you have swelling, you have tumor that's pushing things around. That's never good. Does having 2 primary cancers, breast and pancreatic, make treatment more difficult to preclude some treatments? It doesn't. It just means there's something deeper underlying that process that we would need to better understand and work there. We have a patient here right now that has CLL and prostate cancer. And he's had 3 other types of cancers in his past. Melanoma, colorectal, and I'm forgetting the other one. Great guy from South Carolina. Not going to say go Gamecocks, but from South Carolina, great guy. So yes, it does it make it more challenging and difficult? Sure it does. But that's just part and parcel of going after cancer. So that's a day in the life of taking care of cancer patients. You don't shy away from it. You just have to understand it, test, and develop a precision cancer care program to go after it. Hey, I love this. There's going to be a question about veterinarian vitamin C. This is a great question, talking about our dog. Actually, down in Florida, there's going to be a veterinarian oncologist there. And she's doing some really exciting research on vitamin C in sarcomas for dogs. So absolutely, local hyperthermia is also very effective there as well. Local hyperthermia, vitamin C. In fact, research on looking at vitamin C and hyperthermia really came out of the veterinarian field. So I would encourage now, the environment inside dogs is different than humans, obviously. Yeah, so check out, go to vcici.org. There you'll see a list of the speakers, and there's a veterinarian oncologist there, and she's doing some amazing things. How is important daily diet in your recovery? Absolutely. It's the foundation. I talk a lot about the IV therapies because that's what a lot of people are thinking about, but nutrition is critical to what needs to be done. It is the means to change the terrain. What you eat is a means of communication with your DNA, your genetic code. So you feed it crap, don't be surprised you get crap back. You feed it healthy things, you change the gut bacteria because of eating healthy foods. Research shows you're going to reduce the side effects, the toxic side effects of chemotherapy by 100-fold. You heard me right. The gut bacteria influenced by diet, in a good way, is going to reduce the toxicity of chemotherapy. But research also shows in and of itself it's going to reduce systemic inflammation and it's going to improve cancer therapies, whether they be integrative, holistic, natural, or conventional. Vitamin C and doxycycline for osteomyelitis. Well, yeah, I mean, osteomyelitis it's inflammation of the bone. Vitamin C is an incredible anti-inflammatory. It's antibacterial. It's antiviral. Yes, it's antiviral. It's antiparasitic. It's really amazing. I'm going to be documenting all of this down in Florida, kind of on a timeline table of going through research, how this is just not new. We know this. So vitamin C and doxycycline with osteomyelitis. You know, I'm not familiar with research looking specifically at that, Dana, but that is a good idea. Do you use focus ultrasound for solid tumors in the lung? I guess I don't quite understand the question there, Michael. Focus ultrasound for imaging or for treatment? Not sure. Of course, we use imaging. We use targeted therapies and everything that we can do here. But we do use ultrasound in a wide variety of tumor types. Oh, to break up the tumor. Okay, sorry. We don't really use it there specifically for breaking up the tumor. We have many other therapies that we use. So we use photodynamic therapy. You can do that, but we have other therapies that we use. Well, I am tapped out. It's about 6 o'clock, and so I hope everybody's had a great evening. I tried to answer more questions today. You know what? Try, give us some comments of some things you'd like to hear about, whether you'd like to be here, specific, or more general topics. Oh yeah. So this video will post to our YouTube channel tomorrow. So just post those comments there about what you would like to hear or questions you have, and we'll make sure we incorporate these in our topics and talk about things that are more specific to maybe questions that pertain to you. So I hope you have a great evening, a great rest of your week, and a great weekend, and have a good evening.